I've had a knee replacement and the physio's only doing exercises with me. Is this right? Now, it's very common for exercise-only interventions being applied to people who've had a total knee replacement, especially within the NHS, and certainly at times like this at the moment as well. Now, the dilemma here is I've seen quite a lot of patients who are obviously receiving this within their NHS treatments and they're getting no hands-on intervention, and that's not necessarily a problem, but the patients that have come to see me, of course, are struggling with their exercises, and this could be because their pain is too high, their swelling is too much, they're just struggling to make things happen, or their muscles aren't functioning well. So they come to me to obviously then look into this and see if there's anything extra added to their exercises that can sort of assist and enable that exercise progression. And that's what we do. We look at these people, we apply some hands-on techniques, and the patients that I've seen have done a lot better for it. Their pain levels have dropped, their function levels have improved, their exercise tolerance has increased, their ability to progress their rehab has improved, and their function therefore increases with this as well. So just because I found this, does this mean that we should do this? And what does the research actually say about this exact topic? So is a combination of hands-on treatment alongside exercise better than just exercise alone when it comes to a total knee replacement? So here was a randomized control trial, and they looked at the variables of pain, range of movement, function, quality of life, and patient satisfaction. There were 42 patients who'd all had a total knee replacement for severe osteoarthritis of the knee. And it was on one side only, not bilateral. So the hands-on interventions were joint and soft tissue mobilizations. And of course, these were done with their exercises as well. So the outcome measures to detect the improvements were as follows. So there was a numeric pain rater scale. They measured knee range of movement. There was the WOMAC score, a 10-meter walk test, a 5-time sit to stand test, and a short form 12. So what did they find? So improvements in pain were significantly better in the mobilization and exercise group versus the exercise alone group. The difference is 1.3 points. Now for range of movement, in the earlier stages they did see a difference with the mobilization group being better by 12 degrees. However, by the time they got to this at the end point, there was no real significant difference between exercise alone and exercise combined with hands-on therapies. And they found for all the other measures that the hands-on with combination of exercise was superior to the exercise alone group. And this also included patient satisfaction, which actually would be expected. So in conclusion, this shows you that certainly based on what we've seen here in this randomized control trial, a combination approach might be the best approach for a total knee replacement. Doing some manual therapy alongside exercise therapy is certainly looking to be the best approach. Certainly for patients that I've seen, but remember they've come to me with a specific problem, which means they're already struggling with their exercises, then I've seen this to be very effective. Should it be standardized? Probably not. I think specifically some people don't need that hands-on approach, but some people do, and based on this it shows you that you do get a better outcome on a lot of variables. So it's certainly food for thought, and certainly if you're feeling like you're not getting quite where you need to be with things, say pain is too high, you're not progressing as you should expect or want to expect, you're only getting exercise-based treatment, then it certainly could be a viable prospect to actually complement that with some manual therapy type techniques as well. So anyway, that's it for this video, and I'll see you next time.